It is my honor to introduce to you a person who really needs no introduction, but this is Dr. Chris Whaley. He is a friend and colleague. We have been working on hospital price transparency work for quite some time. He has his PhD in health economics from Berkeley, and with no further ado, I'll just turn it over to Chris. Chris, thank you. No questions.
Great. Well, it's really exciting to be back in Indiana, and after several years of hiccups, to actually be back in person, because Indianapolis is always a fun city to visit. So I'm really excited to present the results of what is now the forthcoming RAND 4.0 study. We're trying to, aiming to have this actually released next week through the RAND website. So just some quick housekeeping acknowledgments. This study was funded by the Robert Wood Johnson Foundation, and we also received funding from Amold Ventures, and also several participating employers who really wanted to see data in their own populations. This study is really a journey with Gloria and Dave and the Employers Forum of Indiana team. And so we've really gone back for several years on iterating on these types of studies. I'm here presenting the work, but this is really the work of a broader team at RAND. So Rosie Kerber, Aaron Kaufner, Brenda O'Neill, and Brian Briscombe. And so I'm sure many people in the room have actually interacted with many of our study team. So just to kind of set the stage and why this is an important question is that employers in the United States really play a critical role in funding the U.S. healthcare system. Across the country, employers provide health insurance benefits for about half of the country, about 160 million people. And collectively, employers spend about $1.2 trillion on healthcare per year, with the largest chunk of the pie going towards hospitals. This is a huge and important market and really plays a vital role in the healthcare system, but it's also faced lots of challenges. And so, as has been mentioned several times, rising healthcare prices really impact healthcare affordability. And so just for some quick look at this, if we look at data from the Kaiser Family Foundation on where healthcare dollars are coming from, we see that they're largely coming from worker benefits and out-of-worker pockets. And so if we look at just the last decade, the amount that workers pay in deductible payments has increased by about 160%. And so many workers, it's not uncommon to have a deductible of $5,000 or more. Insurance premiums for a family have increased by over 50%. I think the average cost of a health insurance premium for a family is now $22,000, and so that's coming directly out of worker paychecks. The inflation rate has increased by 26%, but is now rapidly increasing much faster. And worker earnings are actually less than inflation. So as a society and how we're funding the healthcare system, we are essentially paying workers more in healthcare dollars and less in take-home dollars. And so I personally think that's a policy concern and something that we really need to address. In addition to just understanding where the dollars are going and the impact on workers, employers also have a fiduciary responsibility to monitor healthcare spending and to ensure that healthcare dollars are being used wisely. And so actually, if you go to the Department of Labor website and look at the guidelines for what defines a responsible fiduciary and a responsible health plan fiduciary, fiduciaries have a responsibility to act solely in the interest of plan participants, so their workers and their families, and with the exclusive purpose of providing benefits to them. And so employers have the same fiduciary responsibility for retirement accounts. If my employer RAND was to take my retirement account and put it all into Bitcoin, they would probably get sued or get in a lot of trouble. But if they negotiate a contract that's 500% of Medicare, those are the same dollars. And so our question, and really why we've worked with employers for the last couple of years, is how can self-funded plans who have this legal fiduciary responsibility act as responsible fiduciaries if they don't have information about prices? And so typically, if you think that, look, I'm entrusting you to purchase something on my behalf, you think that the person purchasing a good or service should actually know how much they're spending and what's being negotiated and you're paying. So those are the challenges. There are some who've argued that, well, look, the current system is working well. There was an article about a month ago in one of the Indianapolis newspapers that essentially argues, look, the current system is working, the market's functioning well, and we should just let it continue to work and operate in the most consumer-friendly and business-friendly manner. So that's one argument. But when I teach my students, one of the Econ 101 arguments that I make is that if you're going to have an efficient and functioning market, you have to have information on prices. And so it has been mentioned several times, there are legal requirements for hospitals to post prices. This is the very consumer-friendly and readable tool or website. If you go to a particular hospital system in Indiana and click on their, show me my price, this is what you get. I had 2 master's level programmers at RAND spend about a day each trying to make sense of this. It's challenging. Now that we have Sage, we don't have to do this anymore, so that's great. But this is not something that consumers, employers, others can actually use. And I guess one other note too, there's also been arguments that, well, look, if we use claims data and all that, it's going to be a lag, and so it's not current. This is from a couple weeks ago. And so another argument that I use when I teach my students is that, look, if we're going to talk about prices and markets, we should have a model where prices make sense and we can understand why prices vary across different companies. And so if you go through this data that I just presented, you see that for just a very common surgery, hip replacements, my mom had one a couple weeks ago, prices are really all over the place. And so it probably makes sense that Medicaid and Medicare Advantage plans are paying lower prices, so around the Medicare fee-for-service rate of about $15,000. But when you look at the commercial rates above that, they're really all over the place. So United price is around $28,000, all the way up to over $85,000 for Anthem and Signature EPO. And so it's really challenging for us as economists and people who are understanding this data to understand why there's such wide price variation and why it makes sense to have a hip replacement of $85,000 when other insurers are paying $24,000. And so just to understand why we did the study, we as researchers don't actually know what the right price is, and so our price is too high or too low. That's frankly, I think, where we kind of get over our skis a little bit. But why we wanted to do this study is because the people in the room who actually can say, look, we're spending too much or too low on healthcare services, can't make those decisions if they don't have information about prices. And so how we've designed this tool and the study is to give employers information about the prices that are being negotiated on their behalf, and then allow employers to decide for themselves, are the prices that we are paying too high or too low, or just right, with information about their own markets, their own employee population, and the families of their employees. Just to kind of note the unique time we're in, so we are in COVID, and the after effects of COVID are still being felt. The pandemic has placed a tremendous amount of pressure on hospitals and the healthcare delivery system, but it's also placed lots of pressure on employers, and many employers and HR leaders at many companies have had to make very difficult decisions over the last couple of years. That's in large part because health benefits are one of the largest expenses, and for many employers, the second largest expense after labor. And so I personally think that now more than ever, employers actually need to have information about prices, and if there are difficult conversations, this is the time when we need to have them. So, as I mentioned earlier, this has been a bit of a journey, and so RAND 1.0 actually just started in Indiana, which was led by my colleague Chapin White, who's now at the Congressional Budget Office. For that study, we were able to get data from a handful of employers in Indiana and just highlight the wide variation in prices in Indiana. After that, word got out, if you will, and Gloria was able to take this study on the road, if you will, and go to a bunch of other employers who essentially wanted to know the exact same information of what are the prices that we're paying and how do those align with the value that we're getting. And so in RAND 2.0, we were able to include data from 25 states. And so to expand, we added data not just from employers, but also from some health plans and 2 all-payer claims databases, Colorado and New Hampshire. We were able to look at inpatient and outpatient prices. And then in addition to percent of Medicare, also able to look at standardized prices. And so I'm going to talk about those 2 definitions in a couple minutes. And then 2 years later, we did RAND 3.0. We were able to expand to essentially the entire country. Also added a few more all-payer claims databases, look at professional fees for physicians, and then also add in some information on service level prices. In the results that I'm going to talk about today, we've been able to expand more, and then also get data from 5 additional all-payer claims databases. And so we have what I think is probably the largest collection of all-payer claims databases to look at prices across the country. And then, as Gloria mentioned, we were also able to look at prices for ambulatory surgical centers, and so look at site of care payment differences, and then also add in information on COVID hospitalizations. And so just to understand how we've been able to get this, so our general process is to collect data from individual employers, which are the largest contributor, and then as I mentioned also from all-payer claims databases and a few health plans. We're going to measure prices in 2 different ways. So percent Medicare, which is the probably the most commonly used metric, but then also a price per case mix, which we call a standardized price. And so I'm going to talk about those definitions. We create a public report, and so this is the data that now fuels SAGE and allows anyone to really look and say this is the price across a wide set of payers for a given hospital and given services at that hospital. Unlike many other studies, we're actually able to name individual prices, and so an employer, policymaker, or purchaser can say this is the actual landscape of price variation across hospitals. And then for many employers, this is great to have public information, but employers want to know how much am I paying for my own population. And so we also have an option for employers to essentially subset on their own individual population. Now, when we think about comparing prices, it's something that, frankly, is hard to do. Every hospital is different, treats different types of patients, and so if we're just to compare prices across all hospitals, that would probably be misleading. And so what we're going to do is we're actually going to use a lot of the work that the Medicare system has developed over the last couple decades to make an apples-to-apples comparison. And so like many things, we're going to create what we call the apple pie, but there's more than one way to do it, and so we're going to use 2 different approaches. So our first approach is what we call percent of Medicare, and so what we're essentially doing here is for every single hospital and every single employer claim, we're saying how much would Medicare have paid for the exact same service at the exact same hospital, and how does that compare relative to what the employer paid. What I like about this metric is it's easy to compare, and so we can have a kind of common denominator across all different types of hospitals across the country, and that's the easy way to look at, one hospital is, say, 300% of Medicare, and one hospital is 200% of Medicare. The other advantage of Medicare or percent of Medicare is that Medicare adjusts for things like cost of living differences. So it costs more to hire doctors in New York City than Indianapolis, and so hospitals in New York City get paid a little bit more than hospitals in Indianapolis. It also adjusts for things like some hospitals have lots of uncompensated care, and so those adjustments factor into Medicare prices. Now, some employers may say, look, that's great, and Medicare tries to make a fair comparison in prices across the country and across hospitals, but what we really care about as an employer is just the dollar amount. And so here we're going to not compare relative to Medicare, but still use a lot of the work that Medicare has developed. And in particular, what we're going to do is we're going to look at Medicare's payment differences for different procedures and use that as a way to adjust for different procedures. So, for example, if we saw that one hospital is doing lots of MRIs, one hospital is doing lots of cardiac surgeries, then if we were just to compare prices, that would be misleading. And so we're going to use Medicare's system to adjust for that. And so just as a quick example, if you think of kind of all the range of procedures that a hospital could do, the Medicare system pays a hospital about 35 times more to perform a heart transplant than just to do a simple scan for chest pains. And so for every claim that we get, we're going to use the same level of adjustment to have more of an apples-to-apples comparison. And so the way I kind of think about this is the kind of the average walk out the door amount for employers, and this can say in dollar amounts how much does one hospital cost for inpatient care and outpatient care relative to other hospitals. And then the other advantage is that some hospitals, or some employers rather, maybe just don't want to worry about disproportionate share, uncompensated payments, and teaching hospital payments, et cetera. And so, just to be clear, when we're doing this, we're using the Medicare system really as a price benchmarking system, and really kind of is the chassis that allows us to compare across hospitals across the country. And we're not necessarily saying that hospitals need to be paid what Medicare pays. And so if we were to use this data to say, look, we need to reduce everyone to Medicare rates, that probably wouldn't happen, and it's not clear that that's what we want for the healthcare system. But what we like about using the Medicare system is that Medicare methods are empirical, and so they've been developed over the last several decades with lots of input from providers, and they're designed to be transparent, and so anyone in the room can go to the Medicare website and look at how Medicare pays a given service or a given hospital. And the other advantage of using Medicare rates is that it's something that allows employers to benchmark themselves relative to the largest purchaser of healthcare services in the world. And so what do we find? So our top level findings are that in our new data set, we were able to get data from about 4,000 hospitals and 4,000 ambulatory surgical centers. We find, maybe not surprisingly to people in the room and online, that there's just a tremendous amount of variation in prices across different hospitals and across different states. We find that facility fees are much higher than professional fees, and facility fees really drive a lot of the variation in prices. We also find that prices for COVID hospitalizations mirror inpatient prices, and so a lot of the COVID stays generate revenue that's similar to hospitalizations for other services. And then we also find that prices for ambulatory surgical centers are considerably lower than prices for hospital outpatient departments. And so if we just look at relative prices, and so this is just percent of Medicare for both inpatient services and outpatient services, and then also combining facility fees and professional fees, we find that across the country there's just a huge range in prices. So in some states like Hawaii and Arkansas, prices relative to Medicare are about 150%. So the employers in say Arkansas are paying about 1.5 times what Medicare is paying. Other states like South Carolina and West Virginia, that rate is literally double. And so in South Carolina and West Virginia, employers are paying 300% or more of what Medicare is paying. Just to highlight where we are now, Indiana is actually ranked 7th highest at just under 300% of Medicare. And if we focus a little bit more and kind of unpeel the onion a little bit, and instead of just looking at combined prices, look at prices for just facility services, and so this is how much the hospital gets paid for doing a service, taking out an amount that goes to doctors and healthcare professionals, we actually find that the variation in prices is actually larger, and Indiana actually goes up in the ranking. And so we find that for just facility services, Indiana is actually 4th highest at about 310% of Medicare. And again, states like Hawaii and Arkansas are below 150% of Medicare. And then if we look at this for just inpatient prices, and so this is just for an inpatient hospital stay, how much the hospital gets, we again find that Indiana is 4th most expensive at just under 300% of Medicare. And again, there's almost a 2x variation in prices for inpatient facility fees. We actually find more variation in prices for outpatient facility fees. And so if we look at relative to Medicare, how much Indiana employers are paying for outpatient facility fees, it's actually 6th highest in the country at actually just under 400% of Medicare. And so, to repeat that, employers in Indiana are paying 4 times or almost 4 times what Medicare pays for outpatient services to hospitals. And we, again, find that, that doesn't have to be the case in all states, and actually employers in, say, Arkansas are actually below 150% of Medicare. And so if we look at maybe where Indiana is actually on the opposite end, when we look at just the amount that goes towards doctors, and so this is professional fees, and so taking out the amount that goes to the hospital itself and just focusing on the amount that goes to doctors and healthcare professionals, we actually find that Indiana is 4th lowest at just over 100% of Medicare. And so when it comes to paying doctors, Indiana actually is pretty close to Medicare, but not when it comes to paying hospitals. I mentioned earlier that we were able to get data from 11 all-payer claims databases. We did find that, in general, across those 11 states, or across the country, the 11 states that had an APCD actually tend to have lower prices than states without an APCD, and so we're not, looking, too much into this, and so this could be that states with APCDs are actually able to think more about prices, or it could just be the type of market environment that enables the state to form an APCD. As Hunter mentioned, there are several states, and particularly states towards the upper end, that have actually undergone the work of creating an APCD, collecting lots of data, but they don't actually allow for reporting of provider prices. And so that kind of raised the question of what are the points of those efforts. We were also able to look at prices for COVID hospitalizations. And so here, able to look at, as I mentioned earlier, the standardized price, which is our secondary price of looking at hospitalizations. And what we find is that for just a COVID stay, prices range from just over $10,000 in Mississippi and New Hampshire to over $40,000 in New York and California. And so keep in mind, this is all case mix adjusted. And so if somebody has, say, a 20-day stay and somebody has a 2-day stay, we're adjusting that so we have more of an apples to apples comparison. And so, for a very, new and unfortunately common services, we still see a lot of variation in prices. And if we were to, instead of just looking at the standardized price, look at percent of Medicare for COVID inpatient hospitalizations, which are in the red chart, and then compare that to the average price for a hospitalization across all inpatient services. What we find is that in general, although there's a little bit of range, so, the price that hospitals are getting for COVID care actually mirrors pretty closely what hospitals are getting for all inpatient care. And so I think the takeaway, or at least one implication of this, is that although hospitals maybe are stretched in providing lots of COVID care, these are services that are reimbursed, and in many states reimbursed at a relatively high rate. We were also able, as I mentioned earlier, to be one of the few studies that's actually able to name prices for specific hospital systems. And so here I've got the list of, in our study, at least we were the 20 highest priced hospital systems across the country. And so topping the list, again, is last year is John Muir Health, which is unfortunately where I live. So don't get sick, I guess. And then for these top 20, we find that they're all at or above 350% of Medicare. And so John Muir, again, tops the list at 450% plus of Medicare. And I would also, keep in mind that this is, John Muir is in an area with, world-renowned hospitals. So it's across the bay from University of California, San Francisco Hospital, and just up the drive from Stanford Health. And both of those are world-renowned hospitals. And we don't see them topping the list the same as John Muir. And so this is a tremendous amount of variation in prices for large health systems. And in many markets, we've got lots of variation. So if you go out and buy a car, you can buy a Mercedes. It's probably a better car than if you go out and pay less and buy a Ford or Toyota. And that's a market environment that, look, we're comfortable with. But if we look at the kind of the same dimension for quality for hospitals, we don't really find the same strong relationship. And so what we used for our quality metrics is we used on the left-hand side star ratings collected by Medicare. And so this is essentially sorting hospitals based on their safety and patient experience from a 5-star, which is the highest grade, to a 1-star, which is the lowest grade hospital. And so this is essentially the CMS version of Yelp for hospitals. We were also able to use data on hospital safety scores collected by the Leapfrog group. And so this is measuring things like what are the infection rates at hospitals, et cetera. And here Leapfrog sorts hospitals from a grade of A, which is the best, highest safety score, to F, which is the lowest safety score. And so in general, what we find is that actually the hospitals with the highest CMS star ratings and also the highest safety grade ratings are actually not the highest price hospitals. And so we've bucketed hospitals into the low price, so those less than 150% Medicare, medium price 150 to 250% Medicare, and high price those above 250% Medicare. And so we find that the highest quality and safety hospitals are actually the ones in the middle bucket and not in the highest price bucket. And so this would be the model where you spend a lot to buy a Mercedes, but the Ford actually is a better car. A common explanation that we've gotten for why hospital prices are so high is something that Gloria mentioned, just the concern that, look, we as a hospital have to charge high prices to certain payers, and certain hospitals have to charge higher prices to offset low and underpayments from, say, Medicare and Medicaid, and also uncompensated care. An alternative explanation is that, look, some hospitals are just in unique market environments that allows them to charge high prices. And so we kind of did a horse race between different hospitals and tried to look at which story had more validity. And so on the left-hand side, what we've done is plot each hospital's price relative to Medicare, and so this is the baseline that we've used, and then also plot that hospital's share of non-public discharges, non-private discharges. And so this is kind of the hospital's collection of all Medicare, Medicaid, Medicare Advantage, uncompensated care, charity care, et cetera. And so if what's commonly referred to as the cost shift hypothesis is true, then we should see the hospitals that do lots of non-private care, so you have lots of Medicare patients, treat lots of Medicaid patients, are the ones that have really high prices. Hospitals that have fewer Medicare, Medicaid, et cetera patients should have relatively lower prices, rather. At least when I look at this chart, it looks like a random scatter of dots. And if we do a regression analysis, we get a perfectly flat line, which is the red line here. And so we actually find no relationship between hospital share of public and other patients and kind of what we commonly refer to as underpaying patients and their private prices. And so it can't be that hospitals that are charging higher prices are doing so to offset underpayments from public payers. The other story that we looked at was the market share story. And so we were able to look at across different hospitals, what's their market environment and how much market power do they have relative to that story. And so here we actually do find an upward trend. So hospitals that have more market share are able to charge higher prices. And so maybe that's not surprising for any other market, but at least for hospital care, we find that's certainly the case. The other component that we were able to look at was to look at not just hospital care, but to look at ambulatory surgical center prices. And so ambulatory surgical centers provide many types of outpatient care that are not delivered in a hospital. And then we compared prices for ASCs, both between different ASCs and across different states, but then also took the same ASC and looked at how much it would have been paid if it were, instead of an ASC, a hospital. So one potential disadvantage of using the percent of Medicare to look at ASCs is that Medicare pays ambulatory surgical centers quite a bit lower than a hospital outpatient department. And so if we're just to compare outpatient prices between ASCs and hospitals and just use a kind of broad percent of Medicare, we'd be baking in a lot of those price differences. And so what we did is, in the dark blue line, look at just kind of percent of Medicare based on how Medicare pays ASCs for ambulatory surgical centers. And then in the light blue line, take the exact same ASC and said, well, what if this ASC was paid as if it were a hospital outpatient department and Medicare didn't adjust prices the same way? And so if you remember from a couple slides ago, we found that many states' outpatient prices were 400% or more of Medicare. When just looking at ASCs, we find that they're about 160% Medicare and really not changing over time. And then if we take those same ASCs and say, look, what if these were hospital outpatient departments? Then that same dollar would actually be just above what Medicare pays at about 115% Medicare. And so what we wanted to really highlight is there's just not, it's not just that there's variation in different states and across different hospitals, there's also lots of variation in prices based on who's actually doing the procedure and what the site of care for that procedure is. We did also find pretty wide variation in prices for ASCs. Most states' prices are pretty close to 100% Medicare, but for some states like Alaska and Wyoming, which have unique payment rules for ASCs based in Medicare, prices are quite a bit higher.
ASCs, are you including independent imaging centers, laboratories, in addition to surgery centers? Is this a broad definition of ASC?
That's a good question. We're just focusing on the ambulatory surgical component, and so just ASCs that perform surgery. If we were to look at, say, independent lab, imaging, et cetera, we'd probably find the same thing. And so if you look actually at the Northwestern radiology slide in the back, if we were to map those prices to Medicare prices, they would reflect what we see in ASCs as well. And so if we look at what ASCs are paying relative to Medicare, one way we did this is we just looked at the 5 most common surgical procedures that are performed in an ASC and looked at their average price across all payers, and then looked at prices for hospital outpatient departments that do the exact same procedures, or for the exact same procedures rather, and then repriced everything relative to Medicare. And so what we found is across these 5 most common procedures, the average price at an ASC is about $2,400. Doing the exact same procedure in a hospital outpatient department is about $6,300. And so that's a 2.6 times price gap. And so again, doing the exact same procedure at an ASC instead of a hospital leads to a quite considerable increase in prices. If we were to not use commercial prices, but use our repricing model and to instead say how much would Medicare pay for these exact same services, we still see a price gap. So as I mentioned earlier, Medicare does pay hospital outpatient departments more than ASCs, but the price gap that we see in Medicare is actually lower than the price gap that we see on the commercial side. And so employers and commercial payers are both paying very different prices based on site of care, but they're doing so at an even greater extent than what Medicare does. So those are our main findings, and what are maybe some potential policy takeaways, and maybe how can employers try and use this information. And now it's not just the information in the report, it's really the whole collective of data that they have at their disposal, and looking at very granular level information on price and quality through SAGE. And so as we've worked with employers for the last couple of years, there's really, I think, been a spectrum of how employers are using this data. So some employers on kind of the one end of the spectrum are really excited just to finally have information about prices and to use this information to really think about what's next. Some employers have actually used this data to go out and benchmark prices. And then some have used it actually to pretty aggressively push on hospital networks. So just for the kind of the first phase, some employers are using this information to collect information about prices and to think as an employer group or a policy group about what to do. I think one good example of this is actually the Colorado Business Group on Health, which used our RAND 2.0 data to produce an internal value report that looked at the variation in price and quality across Colorado hospitals, and to think as an employer group, what do we want to do about it? This report provided a couple policy options for the state of Colorado and for employers in Colorado. And it's really been great over the last couple of years to see the state of Colorado and many Colorado employer groups to actually implement many of these proposed suggestions. Some employers are also using this data to actually go out and benchmark prices. Coming back to Indiana, when we presented the RAND 2.0 and RAND 1.0 data, many Indiana employers were really surprised about the variation in prices for outpatient care and recognized that they were paying prices that they considered too high for many outpatient services. And so these employers went back to their insurer and said, look, we want you to go out and negotiate a network that actually caps prices at a % of Medicare for outpatient services. This program was recently implemented, and I think it'll be really great over the next couple of years to understand the impacts and the savings from this type of program. And then other employers are actually using this data a little bit more aggressively. In our RAND 2.0 study, which had 25 hospitals, we actually cited a hospital system in Fort Wayne, Indiana, Parkview Health, as the most expensive hospital system in the country. Many employers saw that and got a lot of attention and essentially went back to their TPA and said, why are you out there negotiating the worst prices for healthcare in the entire world on our behalf, and we're paying you that privilege? And so this led to actually a proactive contract renegotiation between this hospital system and a large insurer in this market that actually led to a new contract that's supposed to considerably lower prices. And so I think this is an example of many employers out there recognizing that look, the prices that we're paying and that we're paying other people to negotiate on our behalf need to be audited, and we need to have insight on what's going on behind the scenes. And if prices are frankly too high, we as an employer group need to do something about it. So just to wrap up, the general takeaway points are that the rising, the continued rise, I should say rather, of healthcare costs place a tremendous amount of pressure on workers, their families, and also employers. And I think this is especially acute during the COVID pandemic and in the next couple of years. The tremendous amount of variation in hospital prices and then also variation in prices for hospital-based and non-hospital-based care presents a tremendous opportunity for potential savings for employers and their families. But in order to do something about it, employers need to have, and not just have, but to demand transparent information on prices that they're paying and that are being negotiated on their behalf. And then it's not just enough to have this information and to look at it, but employers actually need to use this type of information to fulfill their fiduciary responsibility. And areas where prices are high, they need to push back and say, look, we have a legal obligation to our workers to not overpay for healthcare. Thank you, and happy to answer questions.
If anyone has questions for Chris, you can step to the mics. We have had some come in online, Chris, and I know we're a little short on time, but I think we have time for a question or two. We had a couple folks online ask, some hospitals claim they're paid less by Medicare than hospitals in other regions or states, and that's why their prices look high. Is there any validity to this argument? And a similar question, what's the impact of Medicare's variations across the U.S.?
Yeah, so that is a good question. One example is teaching hospitals are paid more from Medicare than non-teaching hospitals. That reflects the Medicare system saying, look, teaching hospitals play a valuable role in training our future healthcare workforce, and so they deserve to be paid a little bit more. Some employers may say, look, that's great and that's a very good societal aim, but we just care about our spending, and so we don't necessarily want to incorporate those amounts. And so that's actually where the standardized price that I mentioned earlier comes in. And so essentially how we've designed it is that kind of anywhere under the sun or using any approach, employers can compare prices, whether it's percent of Medicare or using just the kind of the walk out the door amount of standardized prices.
That was a fabulous presentation, and thanks for all your work on this. I'm confused about site-neutral payments, and you confirm that Medicare pays their reimbursement rate for the same procedure that's done in the hospital versus in an outpatient center is significantly different. Is that's still the case, even with the new site-neutral provision? I mean, if you could explain that in a way that I could understand, I'd really appreciate it.
Yeah. So the simple explanation is that the Medicare site-neutral payment actually applies to physician payments, but not facility payments for things like surgery. The Medicare site-neutral payment refers to physician payments, and so the physician's supposed to get paid the same for the professional fee, whether they're at a hospital or a physician group, but not for the facility payment that accompanies a surgery.
So they're still paying more than the hospital facility.
Exactly.
And if it's outpatient, is there a facility charge there?
Yes. Yes.
Yes.
So there's an inpatient facility charge, outpatient facility charge, and ambulatory surgical center facility charge.
And the site neutral only applies to, so physicians get reimbursed under Medicare now, the same whether they're
That's right.
hospital or outside the hospital.
That's right.
Facilities, there's a difference. Thank you.
All right. Well, thank you. Is that it?